Now I will be talking on piggyback IOL. I have no financial interest in this talk. As a cataract and refractive surgeon, achieving the best possible visual outcome results for your patients is paramount. But sometimes even the best patient selection and most accurate work can result in refractive surprises. So we should have a technique for perfect spherical correction and reversibility. Supplementary IOLs are designed to be implanted in the ciliary sulcus to correct any residual post-operative refractive errors following the implantation of a conventional IOL in the capsular bag. What is piggyback IOL? It essentially means placing one IOL over the other as primary or secondary procedure to get complete correction of lenticular power to achieve zero spherical error. It is a simple procedure, no extra expertise is required. All of us who are doing phaco can do it easily. No extra equipments like excimer laser are needed, and the results are more predictable than IOL replacement, and it is a reversible procedure. I'll skip this history slides. The initial piggybacking that was done by placing the similar IOLs in the bag, like two similar IOLs in the bag, resulted in opaque membranes like this. So thus came the need of safer supplementary IOLs which can be used as piggyback IOL. They are custom made piggyback IOLs. What are the prerequisites for piggyback IOL? We should have AC depth which is minimum 3 millimeters. The primary IOL should be in the bag and the bag should be fused. We should have a stable refraction and there should be no inflammation and no significant post-op IOP rise. We should have a well-dilating pupil. The Sulcoflex lenses are currently only IOLs which are specifically designed to be placed in this ciliary sulcus as piggyback IOL. The lenses have large 14 mm undulating round-edged haptics with a 10-degree angulation. This particular design reduces the risk of contact with the posterior iris as subsequent pigment dispersion. The lens has a round-edged 6.5 mm optic to prevent optic iris capture, especially in mesopic conditions when the pupil dilates, and reduce the likelihood of edge glare and dysphotopsias. The convex-concave configuration, the superior surface is convex and the inferior surface is concave. This particular design of the optic helps to increase the space between the two IOLs, that is the primary IOL which is in the bag and the piggyback IOL, and contributes to avoid the interlenticular opacification that I just showed that was present when we were not having specific piggyback IOLs. It's just a picture how a piggyback IOL is placed in the ciliary sulcus. This is made of reactive material. It has exceptional uveal compatibility. It is the design. There are no vacuoles or glistening. It is a spheric lens. The spherical range varies from 0.5 increments between +10 to -10 diopters. The Sulcoflex multifocal is a refractive. We also have multifocal. Like a patient, we have put a monofocal lens wants a multifocality. We can use a piggyback IOL in that case also. The range is from -3 diopters to +3 diopters with steps of 0.5, and the near add is +3.5, which yields a +3D add at this spectacle plane. We also have a toric IOL which are basically custom made. They are available on orders. Cylindrical power up to 6 diopters minus to plus can be cured with this. Now piggyback IOL, how the power calculation is done. The beauty is that there is no need of biometry. You heard everything is because of the optical biometers, dispersion biometers and everything, but here we don't need biometer. We just need the post-operative refraction needed for IOL power. Like for myopic correction, if the value is -x diopters, this is multiplied by 1.2 to get the IOL power. Example, if we have a -2 surprise, we multiply by 1.2, we get 2.4, we implant a -2.5 IOL. For hyperopic, it is plus x multiplied by 1.5. That is, if we have a plus 3 at the then we have to use a plus 3 into 1.5, 4.5 after IOL. So we have more precise results, as this is independent of biometry and all blah 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 IOL calculation formulas that we heard in the morning. But the limitations are that myopic only up to refractive errors of 8.33 can be corrected, and hyperopic only refractive errors up to 6.67 can be corrected. If we are beyond this, we have to do the IOL replacements or maybe refractive procedures. That will be hearing from Dr. Virendra soon. The complications, as I said, interlenticular opacification, we can get a pupillary block, we can get optic iris capture, which is avoided by this 6.5 mm sign. The edge glare, this is minimized by rounded edges. Uveitis, which is minimized by this typical ray acrylic material, which is having excellent biocompatibility. The contraindications are microphthalmia, active ocular disease, corneal decompensation, AC depth less than 3 mm, unstable capsular bag, or primary IOL not in the bag. The advantages are independent of IOL calculating formulas, easy to implant, no learning curve, no costly equipment like excimer needed, it is a reversible technique. I will show a small video. This is a multifocal lens that I had implanted. An Indian multifocal offered a refractive surprise of -2 diopters. So after waiting for 1.5 months, once the refraction was stable, there was no change in the refraction in that period. I planned to do a piggyback IOL in this case. After I opened the wound, I am injecting HPMC in anterior chamber and beneath the iris. Again, you have to be very gentle. Again, we should be sure that there is enough viscoelastic behind the iris so that there is no, the haptic doesn't get stuck somewhere with the iris. It goes right in the ciliary sulcus. The IOL is injected very slowly here. Let the haptic go behind the iris. Now the leading haptic has gone right into place, and now we have to place the trailing haptic by gently dialing the lens. The plane of the lens needs to be maintained. Only then we will be able to avoid any iris hooking with the haptic. Keep on dialing till we are sure that our haptic is free from any iris hooking. Now comes the most important step, that we need to remove all the viscoelastic. Already we have 2 IOLs in the bag. We may or we may not do a PI, depending on the AC depth and depending on how much sure we are that our haptics are properly placed. Because here the chances of pupillary block with this particular type of piggyback IOL are quite less, as I explained, because of the largest size optic. Then we also need to remove viscoelastic between the 2 IOLs. This I prefer to do with the manual cannula, and I gently tap the lens and then remove it. The wound is sealed. And thus this patient was having 6/6 and N6 uncorrected vision after this particular piggyback IOL implantation. Thank you.